Welcome back to the deep dive. Today we're grabbing our scuba gear for a really significant plunge, actually, into the world of vascular surgery.
That's right.
We're talking about something that impacts millions globally, yet often, flies under the radar. That silent killer that is asymptomatic lower limb peripheral arterial disease.
Mm-hmm.
And you, our dedicated listener, are in for a treat because we're not just scratching the surface here. We're really dissecting the brand new, hot off the press European Society for Vascular Surgery, or ESVS 2024 clinical practice guidelines, specifically tailored for managing this often missed condition.
Yep.
Okay, let's unpack this because honestly, these aren't just minor updates. These guidelines are a genuine game changer, fundamentally reshaping how we understand and approach asymptomatic PAD.
Absolutely.
They're not only crucial for improving patient outcomes, but also, let's be honest, absolutely essential knowledge for anyone tackling their FRCS, their vascular surgery viva.
Precisely. Our mission in this deep dive is really to distill the most critical consultant-level insights from these very recently published ESVS 2024 guidelines.
Right.
Think of this as your strategic blueprint for the diagnosis, prevention, and importantly, the management of asymptomatic lower limb PAD.
Okay.
The source material is the very latest from ESVS, meticulously crafted by a multidisciplinary consortium of specialists. Our goal is to equip you, our listener, whether you're a trainee honing your skills, maybe a seasoned practitioner updating your knowledge, or just someone passionate about advanced medical insights. We want to give you a robust, evidence-based understanding that goes well beyond the textbook. We'll dive deep into the specific recommendations, we'll dissect their levels of evidence, and explore their practical implications, both for those high-stakes exam scenarios and, crucially, for real-world patient care. And what's truly fascinating here, I think, is how these guidelines decisively solidify PAD's role, not just as a localized limb issue, but as a potent warning signal for broader systemic vascular disease. It fundamentally alters our entire management philosophy.
That's a key point.
And just to be clear, we are exclusively focusing on asymptomatic PAD today. We're deliberately stepping around chronic limb-threatening ischemia, or CLTI, that's comprehensively covered by other distinct guidelines, like the ESVS 2020 on acute limb ischemia or the global CLTI guidelines from 2019.
Okay.
So this core message that PAD is a significant marker of systemic atherosclerosis and cardiovascular, or CV, risk is foundational to the entire guidelines approach, and it's a concept you absolutely must master. More Meta 1, Introduction and Scope, Defining the Landscape of Asymptomatic PAD.
So if we're going to talk about managing this condition, we really have to start with a rock-solid definition, right? It sounds simple, but asymptomatic can sometimes be, surprisingly nuanced in clinical practice. How do these new guidelines clarify what we actually mean by asymptomatic PAD?
You're absolutely right. The nuances are key, especially when something is, by definition, without symptoms. So the ESVS 2024 guidelines provide a very clear definition here.
Okay.
Asymptomatic PAD is the presence of obstructive atherosclerotic disease affecting the arteries of the lower limbs, so anywhere from the distal aorta right down to the foot.
Right.
Crucially, this disease is detected by objective tests. That could be non-invasive, like an ankle brachial index, an ABI, showing a value less than 0.9, or maybe through abnormalities identified on imaging studies.
Got it.
The critical phrase, like its name suggests, is that this occurs without exertional leg symptoms. So in clinical terms, we're looking at patients classified as Rutherford 0 or Fontaine I.
Okay, Rutherford 0, Fontaine, no symptom.
Exactly. But this is where it gets interesting in practice. Many patients with actual POD, they don't report those classic exercise-induced leg pains.
Why is that?
Well, there's a whole spectrum of reasons, really. Some might simply be physically inactive or have a sedentary lifestyle, so they never actually exert themselves enough to provoke claudication.
Makes sense.
Others, particularly those with diabetes, might have peripheral neuropathy. That can effectively mask the pain signals that would normally alert them to ischemia.
Ah, right. The neuropathy masking it.
Precisely. Then you've got patients with significant comorbidities, things like severe heart failure, angina, COPD, where their primary limitations just overshadow or even prevent them from experiencing leg symptoms.
So they just can't walk far enough anyway.
Exactly. And sometimes patients unconsciously adapt. They might limit their walking distances or speeds to avoid discomfort without even consciously identifying it as a problem or, a symptom of PAD.
Interesting.
And this whole scenario is distinctly different from intermittent claudication, IC, which is defined by that reproducible exercise-induced leg pain that's relieved by rest.
Yeah.
While these guidelines do touch upon IC, Our intense focus today is on this often missed asymptomatic presentation, precisely because it's such a silent threat.
That makes perfect sense. And for our listeners, particularly those deep in their Viva prep, it's vital to distinguish this from the really severe forms of PAD. Can you explicitly confirm what these guidelines don't cover?
Absolutely. And this is a critical point for precision, both in clinical practice and definitely for any examination.
Hmm.
We have to explicitly state that chronic limb-threatening ischemia, or CLTI, which covers Fontaine III or Rutherford 4-6 categories, is entirely outside the scope of these specific ESVS 2024 guidelines.
Okay, good clarification.
CLTI represents the most severe end of the PA spectrum, characterized by rest pain, tissue loss, or gangrene. It demands urgent attention.
Right.
Its comprehensive management is already addressed by other established guidelines. For instance, the ESVS 2020 guidelines deal with acute limb ischemia, and the Global Vascular Guidelines from 2019 provide the framework for CLTI. So these new ESVS 2024 guidelines, they're laser-focused on the much earlier stages. Early detection, robust prevention, and aggressive risk factor management in patients who are not yet facing an acute or critical limb threat.
So intervening much earlier.
Exactly. The aim is to intervene much earlier in the disease's trajectory, hopefully preventing progression to those severe limb-threatening stages.
Oh.
The overarching purpose of these new ESVS guidelines is straightforward, but, profound. To harmonize and elevate European practice for the diagnosis, prevention, and management of asymptomatic PAD. They provide comprehensive, evidence-based, and frankly, crystal-clear recommendations.
And they're multidisciplinary, you mentioned.
Yes, and it's important to appreciate that this document is the product of a truly collaborative effort, developed by a multidisciplinary group. This isn't just vascular surgeons. It includes angiologists, cardiologists, interventional radiologists, vascular physicians, primary care physicians, exercise rehabilitation specialists.
Wow, quite the team.
It is. And this diverse expertise ensures that the guidelines are practical and applicable across various clinical settings, promoting a genuinely high standard of care for these complex patients.
So it's really about seeing the bigger picture with PAD, not just, a blocked leg artery, but a systemic alarm bell ringing.
Yeah.
What's the core message the guidelines emphasize about PAD's significance beyond the limb itself?
You've hit the nail on the head there. This is perhaps the most fundamental concept, and it's something you absolutely must articulate with conviction in any exam or clinical discussion.
Oh, okay.
The profound importance of PAD as a marker of systemic atherosclerosis and an incredibly powerful predictor of overall cardiovascular risk. These guidelines underscore that lower limb PAD, defined by an ABI less than 0.90, or even an ABI greater than 1.4, which signals incompressible arteries, another form of vascular disease.
Right, the stiff artery.
Exactly. It's far more than just a localized problem. It's a loud and clear warning signal that widespread atherosclerosis is present throughout the patient's entire arterial system.
So what does that mean clinically?
Well, what this translates to clinically is stark. A patient with lower limb PAD, even if entirely asymptomatic in their limbs, faces a significantly elevated risk of major cardiovascular complications elsewhere.
Like heart attack or stroke.
Precisely. We're talking about events like myocardial infarction, MI, or stroke. Recommendation 44 explicitly crystallizes this. It states that for patients with lower limb PAD, an ABI of less than 0.9 or greater than 1.4 should be considered a potent risk-enhancing factor for a cardiovascular event and for increased all-cause mortality.
And the evidence for that is strong.
Very strong. This isn't a tentative suggestion. It's a Class I, Level A recommendation. That signifies the highest level of evidence and clinical importance.
Wow. Class I, level A.
Yep. To put some numbers to it, asymptomatic PAD is linked to a doubling of 10-year rates of coronary events, cardiovascular mortality, and total mortality.
Doubling.
A doubling. And here's a sobering fact. Mortality rates for asymptomatic PAD have remained stubbornly similar to those for intermittent claudication over many decades.
Really? Even though they don't have symptoms?
Even though they don't have symptoms. This persistence highlights the urgent, unmet need for earlier detection and aggressive intervention in this patient group. This perspective moves us beyond simply saving a limb to fundamentally saving a life. It's about recognizing that the disease in the legs is just the tip of a much larger life-threatening iceberg.
Okay.
2. Epidemiology and natural history. The silent threat.
That's a powerful message. And here's where it gets really interesting for me. The sheer scale of asymptomatic PAD. The numbers are quite astonishing given how silently it can progress. It's It's not exactly a rare condition hiding in the shadows, is it?
Far from it. The prevalence is not only substantial, but also growing globally at an alarming rate. Global estimates from 2015 approximated a staggering 237 million PAT cases worldwide,
237 million.
which already represented a 17% increase from just 2010. And what's particularly concerning is that this prevalence is accelerating rapidly in low and middle income countries. We're seeing like a 22.6% relative increase there compared to just 4.5% in high income countries.
Wow, why such a difference?
Well, this global surge can likely be linked to evolving patterns of tobacco use, maybe increased screening efforts, significant demographic shifts, an aging population, and paradoxically, perhaps better access to cardiovascular disease healthcare, which identifies more cases.
Right.
When we focus on the older demographics, specifically adults aged over 65, an ABI less than 0.9 is detected in a significant 10% to 20% of that population.
1 in 5 to 1 in 10 people over 65.
Exactly. And community-based studies, they paint an even more vivid and frankly concerning picture of the disease's silent nature. For instance, in one large general population study, nearly 6,000 individuals aged 50 to 90, a full 18% had PAD, defined by an ABI less than 0.9.
Okay.
And here's the kicker. A striking 62% of those diagnosed were entirely asymptomatic.
Over half.
Over half. The Edinburgh Artery Study, over 1,500 community-dwelling men and women, found 9% had an ABI less than 0.90, but a remarkable 84% of these individuals reported no exertional leg symptoms.
84% asymptomatic.
It's huge. Even the Partner Study, screening almost 7,000 primary care patients in the U.S., reported 29% had an ABI less than 0.90, with nearly half, 48%, of newly diagnosed cases presenting as asymptomatic.
Goodness.
So that the sheer volume of undiagnosed asymptomatic patients quietly living with significant systemic risk is truly immense. Of course, we have to acknowledge that assessing prevalence can be challenging. It varies due to methodology, ABI accuracy, study design, age, population, gender, ethnicity.
Sure, lots of variables.
Right. And this variability only underscores the importance of having a standardized PI definition, universally employing precise ABI measurement.
Those numbers are really quite eye-opening. It underscores the challenge of just finding these patients. And you mentioned earlier that PID is rarely an isolated finding. Does the data confirm that these patients are typically dealing with a broader tapestry of cardiovascular issues?
Absolutely. It's a critical confirmation. What's particularly concerning, and a key point you should definitely integrate into your clinical reasoning, is the extremely strong association of PA with other cardiovascular diseases.
Polyvascular disease, you called it.
Cardiovascular disease, exactly. PAD is rarely, if ever, an isolated finding. It's much more accurately viewed as a prominent red flag for systemic atherosclerosis, signaling disease elsewhere in the arterial tree.
So where else do we see it commonly?
Well, the data consistently supports this. For example, PAD, defined by an ABI less than 0.90, is detected in a significant proportion between 8% and 16% of patients who already have documented coronary artery disease, CAD, on angiography.
Okay.
When these conditions coexist, it's consistently associated with worse clinical outcomes. We're talking higher rates of in-hospital death, heart failure, recurrent ischemia.
Right.
We also frequently observe co-occurrence with carotid artery disease, reported in maybe 14% to 19% of PA patients. However, a crucial point here, especially for exam scenarios, despite this association, there is currently no evidence to support routine screening for PAD based solely on carotid stenosis or vice versa in terms of influencing lower limb outcomes.
Okay, that's important. So screening guidelines are separate for now.
Exactly. The screening guidelines for each remain distinct for now. Chronic kidney disease, CKD, is another major comorbidity. Even mild to moderate CKD significantly increases the risk of incident PAD.
Interesting.
Intriguingly, measures like the estimated glomerular filtration rate, EGFR, and the albumin to creatinine ratio actually improve our ability to predict PAD risk, even beyond traditional predictors.
So check for PAD in CKD patients.
Absolutely. For any patient presenting with CKD, maintaining a high index of suspicion for PAD symptoms is vital, as an early diagnosis can profoundly impact their medical management. Conditions like atrial fibrillation, AF, and renal artery disease are also frequently associated with PAD.
Right.
And what's more, this polyvascular burden tends to compound with age. The proportion of individuals with 2 or more affected vascular beds increases dramatically from a mere 0.04% in those aged 40-50 years to a substantial 3.6% in the 81-90 year age bracket.
Wow, that's a big jump.
It is. It reinforces the idea that PAD is rarely alone. It's a systemic indicator.
So we know it's common, often linked to other serious conditions. But if it's truly asymptomatic, what's its typical course? Does it just, sit there, or does it inevitably worsen? And critically, what's the primary danger for these patients? The limb itself or something, well, even more systemic?
That's the million-dollar question for asymptomatic PAD, isn't it?
Okay.
And it's a critical distinction to grasp. The natural history of asymptomatic PAD is quite variable regarding its progression to symptomatic disease.
Okay.
Estimates suggest that roughly 5% of asymptomatic patients might develop symptoms, like claudication, over a 5-year period. Some studies indicate up to 21% become asymptomatic within just 1 year.
So some do become symptomatic.
Some do.
Right.
However, despite this potential symptomatic progression, the rate of these asymptomatic PAD patients advancing to severe chronic limb-threatening ischemia, CLTI, is relatively low.
Ah, okay. So the limb isn't usually the immediate big threat?
That's a very important point. For asymptomatic PAD, the immediate threat to the limb is generally not the primary concern. The most critical aspect, and this cannot be overstated for your understanding and for the FRCS Viva, is the high systemic cardiovascular event risk.
Right back to the systemic issue.
This is the absolute core message of these guidelines when it comes to asymptomatic PAD. The Ankle Brachial Index Collaboration, a landmark study from 2008 involving 16 population-based cohorts, revealed stark figures.
Okay.
The 10-year cardiovascular mortality for men with an ABI of 0.90 or less was a chilling 18.7%. Compare that to a mere 4.4% for those with the normal ABI.
Huge difference. Hazard ratio of 4.2, you said earlier.
Exactly. Hazard ratio of 4.2. For women, the corresponding figures were 12.6% versus 4.1%, with a hazard ratio of 3.5.
Still very significant.
These numbers are unequivocal. Asymptomatic PAD is a profoundly powerful predictor of future major cardiovascular events like heart attacks and strokes. Furthermore, even in the absence of exertional leg symptoms, asymptomatic PAD patients exhibit greater functional impairment. They experience a faster functional decline compared to individuals without PA. This isn't just subjective. It's driven by underlying pathophysiological changes in the muscles and nerves, things like reduced calf muscle mass, increased calf muscle fat content, compromised peripheral nerve function.
Okay, so real physiological changes.
Absolutely. So, while the limb itself might not be critically threatened in the short term, the patient's systemic cardiovascular health is demonstrably at a very high and immediate risk. We're managing a systemic ticking time bomb, not just a quiet limb. Meaty 3. Diagnosis and screening, identifying the hidden risk.
So given this pervasive silent threat, what does this all mean for actually finding these patients? If we can't rely on symptoms, how do we diagnose something that's, well, by definition, asymptomatic? It sounds like we need a proactive strategy, doesn't it?
You've highlighted the central challenge perfectly. Proactive identification is absolutely key.
Yeah.
In asymptomatic individuals, P8 is primarily detected either through an ABI value below 0.9, maybe as a result of targeted screening, or often through incidental findings on imaging that might have been performed for completely unrelated conditions.
Right, stumbled upon sometimes.
Exactly. The cornerstone for an objective diagnosis, and this is strongly reaffirmed by these guidelines, is the Ankle Brachial Index.
The ABI again?
The ABI.
Ah.
Recommendation 5 unequivocally states that the ABI is the recommended and appropriate test to establish the diagnosis of lower limb peripheral arterial disease.
And the evidence level.
This isn't just a suggestion. It's a Class I, Level B recommendation. That reflects an upgrade in the level of evidence from previous guidelines, signaling a stronger, more robust evidence base.
Okay, Class I, Level B for diagnosis with ABI.
Yes. Furthermore, Recommendation 6 clarifies that an ABI cutoff value of equal to or less than 1.9 is definitively recommended for diagnosis. Importantly, it also instructs that an ABI value of equal to or greater than 1.4 should be considered inconclusive due to incompressible arteries, a critical caveat we need to discuss further. That carries a Class 1, Level C recommendation.
Okay, ABI 0.9 is PAD, or 1.4 is inconclusive.
Yeah, precisely. Now, concerning screening, the guidelines are quite specific. They advocate for a targeted rather than a blanket general population approach.
Ah, okay. Not screening everyone.
No. This is an important distinction for practice. Recommendation 3 explicitly states that for clinically asymptomatic individuals without increased cardiovascular risk, screening for lower limb PAD with ABI measurements is not recommended.
Not recommended, Class.
That's a Class 3 Level B recommendation, primarily because there's insufficient direct evidence to support the effectiveness of general population screening in improving outcomes.
Okay, but you said targeted screening.
Yes, and this is a crucial nuance for our discussion. Recommendation 4 advises that for clinically asymptomatic individuals at increased risk of lower limb PAD, focused screening with ABI measurements, specifically based on the lowest recorded ankle pressure, may be considered to support secondary prevention strategies.
May be considered, so weaker recommendation.
It is. It's a Class II Level B recommendation. This highlights a potential benefit, but in a select group, not for everyone.
That's a vital distinction. So who exactly are these increased risk groups that we should be targeting for screening? Who should we be proactively checking with an ABI?
Excellent question. And the guidelines provide very clear criteria. You should commit these to memory for both clinical practice and exam settings.
Okay, lay them out for us.
Right. These are the individuals we should proactively consider for ABI screening.
Age 65 years or older. Age is a powerful independent risk factor for atherosclerosis.
Simple enough.
Number 2, individuals aged 50 to 64 years who have established risk factors for atherosclerosis. This includes things like diabetes, a history of smoking, current or former, dyslipidemia, hypertension, chronic kidney disease, or a family history of PAD.
Okay, 50-64 with risk factors.
Correct. Number 3, individuals younger than 50 years who have diabetes and at least one other risk factor for atherosclerosis from that list we just mentioned.
So younger diabetics need another risk factor too.
Yes. And finally, number 4, those with known atherosclerotic disease in another vascular bed, such as diagnosed coronary artery disease, CAD, or carotid artery disease.
Polyvascular disease patients again.
Exactly. So the emphasis is very clearly on identifying those individuals who already carry a significant burden of systemic atherosclerosis or are at high risk of developing it. We are not blindly screening the healthy population, but rather focusing our resources where they are most likely to yield actionable insights for prevention.
That targeted screening approach makes a lot of sense, especially from a resource perspective. Moving on to the actual diagnostic tools, can you walk us through the specifics of how an ABI is measured and interpreted? Particularly given the mention of incompressible arteries, which sounds like a potential pitfall.
You're right. The ABI is a simple but precise tool, and understanding its nuances, especially that pitfall you mentioned, is vital. Proper technique is paramount.
Okay, so how do we do it right?
To measure it, you need a continuous Have Doppler probe and an appropriately sized blood pressure cuff, ideally, about 40% of the leg circumference to ensure accurate readings. Before measurement, the patient should rest supine for 5 to 10 minutes to allow their blood pressure to stabilize.
Rest is important.
Crucial. You start by measuring the systolic blood pressure, SBP, in each arm. If there's a difference of 15 millimol Hg or more between the arms, it should raise a suspicion of subclavian stenosis, which might influence your interpretation.
Good point. Then the ankles.
Then you measure the SBP of the posterior tibial and anterior tibial arteries in each foot. The cuff is inflated to 20 millimil Hg above the point where the Doppler flow signal disappears, with a maximum inflation of 250 millimil Hg to avoid discomfort or injury.
Okay, and the calculation.
For calculating the ABI, the highest SBP from both arms is used as the denominator. Now, here's a critical distinction the guidelines highlight. For standard diagnostic purposes in symptomatic patients or for routine surveillance, you typically use the highest ankle SBP in each leg.
Right.
However, if the ABI is being specifically utilized as a cardiovascular risk marker, which is often the primary reason for measurement in asymptomatic PAD, it's recommended that the lowest ankle SBP is divided by the highest arm SBP.
Lowest ankle pressure for risk assessment.
Exactly. And this specific method for CV risk assessment is itself a Class I, Level B recommendation, underscoring its importance.
Okay, and interpretation. We know A0.9 is PAD. What about WinAll 1.4?
Right, interpretation. ABI equal to or less than 0.90 definitively confirms PAD. Now about that pitfall. An ABI equal to or greater than 1.40 indicates incompressible arteries.
The stiff ones.
The stiff ones. This commonly occurs in older individuals, patients with long-standing diabetes, or those with chronic kidney disease where medial calcification stiffens the artery walls, preventing accurate compression by the cuff.
So the reading is falsely high.
Potentially, yes. When this happens, the ABI is inconclusive. In such scenarios, if clinical suspicion for PAD remains high, a post-exercise ABI drop of 20% or more, or an ankle pressure decrease greater than 30 millimol Hg can help confirm PAD.
Okay, exercise testing can help there.
It can.
So when the ABI is inconclusive because of incompressible arteries, we can't just give up, right? Are there alternative non-invasive tools we should turn to in those, trickier cases?
Absolutely not. We certainly don't give up. For those individuals with a clinical suspicion of PA but an inconclusive ABI due to incompressible arteries, recommendation 9 states that the toe brachial index, or TBI, or absolute toe pressures should be considered as additional diagnostic tools.
TBI, okay. Recommendation level.
This is a Class 3I Level B recommendation reflecting a strong consideration. Furthermore, Recommendation 10 advises that for individuals with a clinical suspicion of PI despite a normal ABI, perhaps they have atypical symptoms or strong risk factors, TBI, or absolute toe pressure should also be considered to confirm PI.
Even with a normal ABI?
Even with a normal ABI, though, this carries a Class 3I Level C recommendation, indicating a weaker evidence base but still a valid approach.
And why toes?
The key rationale here is that the digital arteries, the toe arteries, are much less prone to medial calcification and incompressibility compared to the larger ankle arteries. A TBI of less than low 0.7 is generally considered abnormal and indicative of PI.
TBI 0.7. Okay. What about imaging? Duplex, CT, method.
Right. Beyond these physiological measurements, medical imaging plays a crucial role in selected cases, though not typically for initial screening.
Okay.
Duplex ultrasound is a real workhorse, boasting over 85% sensitivity and over 95% specificity. Its advantages are clear. Low cost, no radiation, non-invasive.
Standard practice.
Very much so. Computed tomography angiography, CTA, offers impressive performance. Over 90% sensitivity and specificity allows imaging of the entire vascular tree pretty quickly. But drawbacks include radiation exposure and the risk of contrast-induced nephropathy.
Right, the kidneys.
Exactly. Magnetic resonance angiography, MRA, also provides excellent sensitivity and specificity, again, over 90%. Images the whole vascular tree and critically involves no ionizing radiation.
Big plus downsides.
Limitations include the absence of calcium burden information, potential issues with metal stents, higher cost, patient claustrophobia, and the small theoretical risk associated with gadolinium contrast agents, though this risk is minimized with newer Group 2 agents. Newer non-contrast MRA techniques are also showing great promise. But generally, these advanced imaging modalities are reserved for detailed anatomical assessment, primarily when an intervention like revascularization might be considered. However, and this is a critical point for asymptomatic PAD, revascularization is very rarely, if ever, indicated, as we will emphasize later.
Got it. Imaging, mainly if symptoms develop or intervention is somehow contemplated, which is rare here. Mind more. Risk factor modification, the cornerstone of care.
Now, this section is absolutely fundamental. For asymptomatic PAD, the entire management strategy pivots around a robust secondary prevention model.
Respiratory prevention.
Yes, this is not about rushing to revascularize a limb. It's about strategically safeguarding the patient's entire cardiovascular system from future major events. And it begins, unequivocally, with aggressive risk factor modification.
That's a crucial distinction. So it's less about immediate surgical intervention for the limb and much more about tackling the underlying systemic disease and protecting the whole patient. Let's delve into those cornerstone lifestyle factors. What should be our absolute priorities here?
Exactly right. Lifestyle modifications are, without a doubt, our first and most potent line of defense. Let's start with smoking cessation because, frankly, nothing else comes close in terms of impact.
It's a big one.
The big one. Recommendation 21 unequivocally states that for all patients with lower limb PAD who smoke, both behavioral interventions and pharmacotherapy for smoking cessation are recommended. Both. This combination offers the most effective means for successful, sustained cessation. And this is a Class I, Level A recommendation, the highest possible, reflecting irrefutable evidence.
Can't argue with Class I, Level A.
You really can't. The impact of smoking is devastating. It's the leading preventable cause of disease and death globally, and it stands as the strongest modifiable risk factor for PAD development, accelerated progression, significantly increased need for revascularization, risk of CLTI, and even amputation.
Grim picture.
It is. The good news, however, is equally profound. Improved outcomes are consistently seen with cessation, and it also dramatically reduces the risk of associated cancers like lung and bladder cancer.
Okay, so what works for cessation?
When it comes to interventions, intensive counseling has proven highly effective. One randomized study in PA patients demonstrated a 21.3% abstinence rate at 6 months compared to just 6.8% with minimal intervention.
Counseling helps a lot then.
Definitely. For pharmacotherapy, options like varenicline, which is often recommended first line due to its efficacy, that's a Class I, Level B recommendation in Recommendation 23 bupropion, and nicotine replacement therapy, NRT, are all demonstrably more effective than placebo.
Okay.
Often, combination therapy, like NRT plus bupropion or varenicline plus bupropion, proves even more effective. And critically, Recommendation 24 advises a follow-up contact within 2 to 4 weeks after initiating a quit attempt.
Why so soon?
This early contact is vital to monitor adherence, assess response, manage any side effects, basically supporting the patient through this challenging but life-saving process.
Makes sense. What about e-cigarettes?
Yeah, e-cigarettes are sometimes debated. These ESVS guidelines, after considering potential harms, keep the focus on established, proven cessation methods.
Okay, stick to the proven stuff. What about exercise? They're asymptomatic. Do they still need it?
Yes, next let's consider exercise and physical activity. Even though these patients don't have claudication, it's a common misconception that they are functionally normal.
Oh.
On the contrary, asymptomatic PA patients often demonstrate impaired lower extremity function. Studies consistently show they have poorer results in tests like the 6-minute walk test, exhibit slower walking speeds, and even possess smaller calf muscle areas compared to individuals without PAD.
Interesting.
They also experience a faster rate of functional decline. Therefore, advising regular physical activity is important, aligning with general healthy lifestyle recommendations. That means at least 150 to 300 minutes per week of moderate intensity aerobic activity, or maybe 75 to 150 minutes per week of vigorous intensity activity.
So same general advice applies.
Pretty much. This isn't about curing their PAD per se, but about improving overall cardiovascular fitness and functional capacity.
Right, and diet.
Finally, healthy diet and weight management. Dietary changes are fundamentally important for addressing key cardiovascular risk factors like obesity, high cholesterol, hypertension, and diabetes.
Any specific diet recommended?
Well, for instance, the Mediterranean diet has consistently shown significant health benefits. It's been shown to reduce the risk of major adverse cardiovascular events, MAC, by about 30% when supplemented with extra virgin olive oil or nuts.
Okay, Mediterranean style. And weight.
We should strongly encourage patients to aim for a body mass index, BMI, between 18.5 and 24.9 km. Cardiovascular risk dramatically increases with a BMI over 30 km.
Standard BMI targets.
Exactly. Recommendation 26 considers comprehensive screening for cardiovascular risk factors with subsequent optimal management as a strategy to reduce both limb disease progression and overall cardiovascular risk. That holds a Class IA, a Level C recommendation.
Okay, so lifestyle is huge. Smoking, exercise, diet, weight.
Foundational, absolutely foundational.
Those lifestyle interventions are clearly foundational and in some cases truly transformative. But let's be realistic. For many patients, lifestyle alone isn't enough, is it? What does the guidelines say about pharmacotherapy? Where do medications fit into this secondary prevention model?
You're absolutely right. Pharmacotherapy forms another critical pillar for these patients, primarily focused on systemic cardiovascular protection. Let's tackle the crucial updates one by one.
Okay.
First, and this is a major divergence from previous practice that we'll delve deeper into shortly, antithrombotic therapy. For asymptomatic PAD patients, antithrombotic therapy is not routinely indicated unless there are other compelling concomitant indications, such as documented coronary artery disease or a history of previous stroke.
Okay, we'll come back to that big change. What else?
Next, statins, or lipid-lowering agents. This is unequivocally a cornerstone therapy for these patients. Recommendation 29 states that for all patients with asymptomatic lower limb PAD, high-intensity statin treatment is recommended.
All of them.
All of them. The goal is to robustly reduce the subsequent risk of major cardiovascular events, limb events, and disease progression. This is a Class I, Level C recommendation.
Class I, Level C for high-intensity statins. What are the targets?
The specific targets are ambitious and clear. An LDL cholesterol level of less than 1.4 millimol, that's less than 55 milli-GDL, and critically a reduction of at least 50% from baseline if the baseline values were already within the 55 to 110 milli-GDL range.
Okay, 1.4 and 50% reduction. What's the evidence for that target?
That specific target comes with a Class I, Level B recommendation, under Recommendation 32. It's vital to recognize that PAD patients, by virtue of their diagnosis, are automatically categorized into the very high-risk group for dyslipidemias.
Right, they're already high risk. What about older patients?
Good question. For our elderly patients, specifically those over 80 years, Recommendation 30 advises that statins should be offered with the same indications, but with appropriate caution regarding polypharmacy and potential impaired organ function. That's a Class I, Level A recommendation.
Okay, same indication, just more caution. What if statins aren't enough?
If those lipid targets aren't reached despite high-intensity statin therapy, Recommendation 33 recommends adding ezetimibe. That's a class 1 level C recommendation.
As a maybe second line, what about PCSK9 inhibitors?
Regarding PCSK9 inhibitors, recommendation 34 states they are not recommended as first-line therapy. That carries a class 3 level C.
Not first line. When would we use them?
They may be considered for patients who are genuinely unable to reach their lipid targets or are truly intolerant to statins and ezetimibe. Secondary analyses from trials like FORIA did show benefits, a 21% reduction in MACE and a 42% reduction in major adverse limb events in a PAD-P subcohort, but long-term safety data, particularly in a broader population, and economic considerations still limit their first-line use.
Okay, and statin intolerance. It comes up a lot.
It does. When managing statin intolerance, it's worth remembering the potential for a nocebo effect, where a significant portion of symptom burden can be attributed to patient expectation rather than the drug itself, as famously shown in the Samson trial. Management often involves careful dose reduction or switching to an alternative statin.
Right, manage expectations and try alternatives. Okay, lipids covered. Blood pressure.
Moving on to blood pressure control. This is another Class A recommendation. Recommendation 35 advises clinicians to reduce blood pressure to equal to or less than 120, 100, 900, 980 mmHg in patients younger than 70 years, and to equal to or less than 130, 130, 980 mmHg in those 70 years or older.
Okay, slightly different targets based on age. Evidence.
The primary objective is to reduce the risk of major adverse cardiovascular events. This is a Class I, Level A recommendation.
Class I, Level A again. Which drugs?
Recommendation 36 suggests a stepwise approach for antihypertensive pharmacotherapy with ACE inhibitors, ACEI or angiotensin receptor blockers, ARBs, plus dihydropyridine calcium channel blockers being preferred. Ideally, for improved adherence delivered as a one-pill combination.
ACEs or ARBs first line.
Yes. The landmark FOOP trial, which used ramipril, compellingly demonstrated a reduction in cardiovascular events in both symptomatic and asymptomatic PED patients. And the absolute benefits were actually twice as large in those with an ABI less than 0.9.
Wow. Really reinforces the need for BP control here.
Absolutely. Aggressive blood pressure control in this population is critical.
Okay. What about diabetes, another huge risk factor?
Diabetes control is equally critical. Recommendation 37 advises reducing blood glucose to near normal HbA1c values, typically equal to or less than 7%, which is 53 millimole, to effectively prevent microvascular and macrovascular complications. This is a Class I, Level A recommendation.
Standard HbA1c target. Any specific drug classes highlighted?
Yes, and this is a truly significant update. It comes in recommendation 38. For patients with PPE and type 2 diabetes, both SGLT2 inhibitors and GLP-1 receptor agonists are recommended as first-line hypoglycemic agents to reduce the risk of major cardiovascular and renal events.
Both first line. That's big. What's the evidence?
This is a Class I, Level B recommendation. Trials such as CANVAS, MPREG outcome, declared TIMIUS 58, DAPA-CKOD, and DAPA-HF have unequivocally demonstrated significant cardiovascular and renal benefits for SGLT2 inhibitors.
Right, those big outcome trials. What about the amputation risk signal with SGLT2s?
Good point. It's important to be aware of the initial concern about amputation risk that emerged with canagliflozin in the CANVAS trial. However, later trials like MPREG and DECLARE did not confirm this signal, offering significant reassurance regarding the class effect.
Okay, so that concern seems less prominent now. Anything else on meds?
Finally, we have vaccination. Recommendation 40 recommends full vaccination against COVID-19 disease for PAD patients. This is due to their demonstrably increased risk of hospitalization with severe COVID-19 illness. That's a Class I, Level C recommendation.
Okay, COVID vax. Influenza.
Similarly, influenza vaccination is strongly recommended due to the increased risk of hospital stays for influenza and other respiratory issues in PD patients, despite historically low vaccination rates in this vulnerable group. These are simple yet powerful preventative measures.
Definitely important public health measures. 5v5. Antithrombotic therapy key 2024 update. A major shift. Now let's talk about one of the most significant updates in these guidelines. This particular area, antithrombotic therapy, has always generated a lot of discussion in the clinic, and I can tell you is a perennial favorite for examiners trying to trip up trainees. I've personally seen so many shifts in practice here over the years.
You've hit on perhaps the most critical update in the entire document, and it represents a notable divergence from long-held practices, particularly concerning aspirin for asymptomatic PAD. You, our listener, will want to pay very close attention here, as this is a clear and decisive shift in recommendation based on robust cumulative evidence.
Okay, everyone listen up. What's the big news?
The most important takeaway, the one you absolutely cannot miss, is the absence of a blanket recommendation for aspirin in asymptomatic PAD. Recommendation 43 is emphatic and leaves no room for ambiguity.
Okay, what does it say exactly?
It says, patients with asymptomatic lower limb PAD without other contemporary indications for antithrombotic treatment should not be treated with aspirin, as bleeding risk and side effects are likely to outweigh the benefit.
Wow, should not be treated that strong. Class and level.
This is a Class 3 Level A recommendation.
Class 3 Level A against aspirin.
Exactly. For those preparing for exams, understanding this specific recommendation, its class and its level of evidence is absolutely critical. This isn't a subtle suggestion or a nuanced interpretation. It's a strong, definitive statement against routine aspirin in this specific patient population.
So why the change? Aspirin seems standard for so long.
It clarifies a previous ambiguity that often led to widespread, unsubstantiated aspirin use for primary prevention in asymptomatic PV. This is a paradigm shift, challenging decades of clinical intuition and default prescription habits.
That's a very clear and forceful message against routine aspirin use. So what's the underlying rationale? Why this dramatic shift away from what many clinicians might have considered standard practice for years?
The rationale is incredibly robust. It stems from a comprehensive reevaluation of the risk-benefit balance based on cumulative evidence from multiple randomized controlled trials and meta-analyses.
Which studies were key?
This recommendation is primarily driven by studies like POPADAD, the Prevention of Progression of Arterial Disease and Diabetes trial, and also supported by extensive meta-analyses, like the one by Ambler et al. In 2020. These studies consistently demonstrated that primary prevention with aspirin alone offers no clear significant benefit in asymptomatic ABI-positive patients when weighed against the very real risks.
No clear benefit. But what about the risks?
Well, while some analyses of antiplatelet monotherapy showed a very small absolute reduction in non-fatal stroke, this was consistently offset by a statistically significant increase in major bleeding risk.
The bleeding risk.
The key here is the balance. When you meticulously scrutinize the data specific to asymptomatic PAD, the potential harm from bleeding complications, which can be severe and life-threatening, simply outweighs the very modest, if any, benefit in preventing ischemic events in patients who are, by definition, asymptomatic of limb-threatening ischemia.
So the harm outweighs the good in this specific group.
Precisely. This isn't about ignoring atherosclerosis. It's about making a data-driven decision for primary prevention where the drug's harms outweigh its benefits in this specific context.
So to be absolutely crystal clear for our listeners, especially those managing complex patients, are there any situations where antithrombotic therapy is indicated for a patient who happens to have asymptomatic PAD? Or is it just a complete no-go across the board?
That's a crucial point for clinical precision. It's not a complete no-go across the board. It's about understanding the primary indication.
Okay.
Antithrombotic therapy is indicated if there are other compelling coexisting conditions that independently warrant antiplatelet or anticoagulant therapy.
Such as?
For instance, if the patient has documented coronary artery disease, CAD, a history of a previous ischemic stroke or transient ischemic attack, or any other high cardiovascular risk condition like atrial fibrillation requiring anticoagulation that requires antithrombotic treatment, then absolutely they should be on it.
Right, so if they need it for something else anyway.
Exactly. In these scenarios, the asymptomatic PA simply becomes another risk factor that contributes to the overall cardiovascular risk assessment, further solidifying the need for antithrombotic therapy. But it is the concomitant disease, not the asymptomatic PAD itself, that serves as the primary indication for antiplatelet use.
Yeah, distinction is vital. The PAD isn't the reason for the aspirin in that case.
Precisely. We're treating the other high-risk condition, and the PAD just reinforces the systemic risk. Moreover, it's important to remember that for symptomatic PAD patients, those with intermittent claudication or especially CLTI antithrombotic therapy is generally indicated, often with more aggressive strategies. But again, these are distinct patient populations.
Right, different rules for symptomatic patients. And what about dual pathway inhibition, like combining low-dose rivaroxaban with aspirin? We've seen a lot of discussion around that in broader cardiovascular and even symptomatic PAD contexts. Does that have any place in our asymptomatic PAP patients?
That's an excellent, astute question, and it's essential to be extremely precise here, especially when differentiating for exam purposes. dual pathway inhibition, DPI, which typically involves combining a low-dose direct oral anticoagulant like rivaroxaban with aspirin, as rigorously studied in trials like COMPASS and Voyager PAD,
Right, those big trials.
is not recommended for asymptomatic PAD.
Not recommended here either. Why not?
The key is to remember the patient populations in those trials. COMPASS enrolled a broad range of stable atherosclerotic disease patients, including those with PAD, and showed benefits in reducing MACE, but it included patients who were already symptomatic or had established vascular disease.
Okay, not purely asymptomatic.
Right. Similarly, Voyager PAD specifically looked at patients who had undergone revascularization for symptomatic intermittent claudication, or CLTI.
So post-intervention patients.
Exactly. These are very distinct, much higher risk patient populations compared to the asymptomatic individuals we are discussing today who have not experienced limb symptoms and have not undergone recent revascularization.
Makes sense.
So, while DPI has a significant and crucial role in specific high-risk symptomatic or post-intervention PAD patients, it absolutely does not apply to the asymptomatic population according to these ESVS 2024 guidelines. Always make this crucial distinction clear, particularly when faced with an examiner's probing questions.
Got it. DPI is for symptomatic or post-revasc PAD, not asymptomatic A6, cost effectiveness and health policy, the broader view. Beyond the direct clinical benefits for individual patients, these guidelines also touch upon the practicalities of healthcare systems and resource allocation, don't they? It's not just about what we can do, but what makes sense on a larger scale, especially when we're talking about preventative strategies.
You've tapped into a really important dimension. If we zoom out and connect this to the bigger picture, the economic impact of early preventive strategies in asymptomatic PAD patients is actually quite profound and often underestimated.
How so?
When we analyze the cost effectiveness, particularly of statin therapy and broader cardiovascular risk modification, the evidence is compelling. It is consistently highly cost-effective in asymptomatic PAD.
Highly cost-effective.
Yes. Earlier models, like one by Sigvent et al., back in 2011, estimated that aggressive interventions like ACE inhibition, statins, and even clopidogrel at that time, before the current guideline shift, significantly reduced cardiovascular events and generated substantial quality-adjusted life years, or QALYs.
Okay.
It's worth noting, even then, aspirin in that specific model demonstrated a statistically non-significant hazard ratio for event reduction, kind of foreshadowing the later guideline change we just discussed.
Interesting. Any more recent data?
Yes, more recently, Atoga et al. In 2014 reevaluated the cost-effectiveness of a strategy involving one-time ABI screening at age 65, followed by comprehensive medical therapy for those with positive screen.
Okay, screen at 65, then treat positives. What did they find?
This strategy yielded an incremental cost-effectiveness ratio, or ICER, of about $88,758 per QALY gained over a 75-year horizon.
And how does that compare? Is that considered good value?
It compares quite favorably to generally accepted thresholds for cost-effectiveness in healthcare, suggesting it's a worthwhile investment from a public health perspective.
That sounds promising for targeted screening. So if the medical therapy is cost-effective once patients are identified, why isn't general population screening with ABI more broadly recommended? That still feels like a slight disconnect, maybe?
That's a very perceptive observation, and it highlights a nuanced area where the evidence, while evolving, remains mixed. It underlines the need for further high-quality research.
Okay.
While targeted screening for high-risk groups, as outlined in Recommendation 4, may be considered, general population screening for ABI is not recommended, as per Recommendation 3.
Right.
This isn't because we doubt the benefit of medical therapy for diagnosed individuals, but rather due to a lack of robust direct evidence for the effectiveness of widespread screening in the general population in improving hard clinical outcomes.
So the screening itself hasn't been proven to save lives on a population level?
Not definitively, no. Consider the multi-component screening trials, like the VV trial and the Dancavis trial, both conducted in Denmark.
Okay.
These programs included ABI screening as just one component of much broader, comprehensive cardiovascular screening initiatives. However, none of these trials independently tested the effectiveness of ABI screening alone in specific populations.
It was part of a package deal.
Exactly. For example, the VVA trial, over 50,000 men aged 65-74, randomized them to either comprehensive cardiovascular screening or a non-screening control group. After a median follow-up, they observed a reduced overall mortality risk in the screening group.
So it worked.
Well, yes, but this benefit was primarily linked to the initiation of pharmacological risk-reducing therapy after diagnosis, rather than the screening itself as an isolated intervention. Screening in Viva did appear cost-effective, though. About $6,872 per life year, $2,148 per QEL.
Okay, cost-effective there. What about Dancavis?
However, the Dan Cavas trial, a much larger study involving over 46,000 men, which also incorporated ABI measurements as part of extensive cardiovascular screening, did not find a statistically significant reduction in all-cause mortality after 5 years. The hazard ratio was 0.95, p-value 0.060, just missing statistical significance.
So conflicting results, kind of.
A bit mixed, yes.
Yeah.
And the key point of uncertainty in these ICER calculations lies in our understanding of the long-term effects of medication on asymptomatic PAI patients. This is due to a relative paucity of high-quality long-term trial data, specifically in this subgroup.
Okay.
So while early identification and aggressive medical therapy are undeniably beneficial for those diagnosed with asymptomatic P, the evidence to support widespread, unselected general population screening for ABI alone, especially when considering the operational complexities, potential for overdiagnosis leading to patient anxiety, and downstream costs, is still evolving.
So more research needed on pure ABI screening.
Therefore, the guidelines conclude that further high-quality randomized controlled trials, specifically focusing on ABI screening alone, are needed to definitively address this question from a public health policy perspective and clarify its broader utility. 7. Clinical application for FRCS, vascular surgery, VIVA, mastering the examination.
For those preparing for the FRCS Viva, how you articulate your understanding of asymptomatic PA is absolutely critical. You're not just reciting facts, you're demonstrating nuanced clinical judgment and a truly up-to-date grasp of these guidelines. Let's frame this from an examiner's perspective because they'll definitely be looking for that consultant-level insight.
That's an excellent way to think about it. This raises an important question. How do you demonstrate a consultant-level understanding and navigate an asymptomatic PAD scenario with precision and depth in an exam? It's really about linking the evidence to practical, decisive clinical action.
Okay, so what's the first thing to hammer home?
First, and this is perhaps the single most crucial point, always emphasize PAD as a systemic disease marker. Your answer must consistently convey that asymptomatic PAD is not merely a localized limb problem.
Right, the core message again.
Instead, it is a powerful, undeniable indicator of widespread atherosclerosis and, critically, significantly heightened systemic cardiovascular risk for major adverse events like MI, stroke, and overall mortality. This foundational perspective must underpin all your subsequent management discussions.
Any specific recommendation to quote?
Yes, if you can reference Recommendation 44 at Class I, Level A recommendation stating that an ABI of 0.9 or 1.4 is a potent risk-enhancing factor for CV events and all-cause mortality, you'll score highly and immediately establish a strong contemporary understanding.
Okay, emphasize systemic risk, quote, Rec 44. What's next?
Second, you need to clearly present the management paradigm for asymptomatic PAD primarily as a secondary prevention model focused on averting systemic cardiovascular events.
Okay, secondary prevention model. What does that involve specifically?
Your strategy should center on lifestyle modifications. Emphasize smoking cessation as absolutely crucial. Detail that this requires both behavioral interventions and pharmacotherapy, citing it as a Class I, Level A recommendation. Also mention the importance of a healthy diet and regular physical activity.
Lifestyle first, then meds.
Pharmacotherapy. This means advocating for high-intensity statins for all patients, citing Recommendation 29, Class I, Level C. Insist on optimal blood pressure control, discussing the specific targets for different age groups, and mentioning ACE inhibitors or ARBs as preferred first-line agents, citing Rec 3536, Class I, Level A, and for diabetic patients, stressed tight diabetes control, specifically highlighting SGLT2 inhibitors and GLP-1 agonists as first-line hypoglycemic agents for their cardiovascular and renal benefits, citing Rec 38, Class I, Level B.
Okay, comprehensive medical management. What about intervention?
Third, be crystal clear and unequivocal. Revascularization is not indicated for asymptomatic PAD. There is absolutely no role for endovascular or open surgical intervention to improve limb blood flow in the absence of symptoms.
Oh, not at all.
None. The entire goal here is systemic risk management, not revascularizing a non-symptomatic artery. This is a point an examiner will almost certainly probe, looking for your conviction.
Okay, be firm on no revasc. What else might they ask?
Fourth, anticipate the classic antiplatelet therapy, an examiner's trick question. They will ask about aspirin.
Right. The big change. How should we answer?
Your answer must be precise and directly reference the new guidelines. Not routinely, unless there are other clear comorbid cardiovascular indications, such as established coronary artery disease, a prior stroke, or atrial fibrillation requiring anticoagulation that independently warrant antiplatelet therapy.
Okay, and mention the specific guideline.
Critically, make sure to cite the ESVS 2024 guideline, specifically Recommendation 43, which is a Class 3 Level A recommendation against aspirin for asymptomatic PID due to the bleeding risk outweighing any potential benefit. This demonstrates truly up-to-date knowledge and avoids falling into outdated paradigms.
Class 3, Level A against routine aspirin. Got it. Anything else to impress the examiner?
Finally, to add significant depth and demonstrate comprehensive understanding, you must show knowledge of key trials relevant to asymptomatic PPA management.
Okay, which trials are must-knows here?
POPADAD. This trial is essential to mention when discussing aspirin, as it compellingly demonstrated no clear benefit of aspirin for primary prevention in asymptomatic ABI-positive patients. It directly underpins that Class 3 recommendation.
POPADAD for aspirin.
Canvas, MPR-REG outcome, and Declare Time E58. These trials are vital for discussing SGLT2 inhibitors and their profound cardiovascular and renal benefits in type 2 diabetes. Be prepared to discuss the initial amputation signal observed with canagliflozin in Canvas and its subsequent non-replication in later trials like MPA-REG and Declare, showcasing a nuanced and balanced understanding.
Okay, SGLT2 trials and the amputation discussion.
HOPE trial. This trial showed that ramipril, an ACE inhibitor, significantly benefited at reducing cardiovascular events in patients with both symptomatic and asymptomatic PAD, with the absolute benefits actually being greater in those with an ABI less than 0.9. This powerfully reinforces the importance of aggressive blood pressure control.
HOPE trial for AC inhibitors. What about trials like UC-LIGHT or COMPASS?
Be cautious and precise when referencing trials like UC-LIGHT, COMPASS, and Voyager PAD. While they are undeniably important for understanding PAD in general, or for symptomatic and revascularized patients, clarify their specific applicability.
How so?
UC-LIGHT, for instance, assessed outcomes related to ticagrelor versus clopidogrel in symptomatic PAD patients. While it provides context on the high cardiovascular risk of PAD patients, it does not directly inform antithrombotic therapy for asymptomatic PAD.
Okay, UC-LIGHT for symptomatic context. Voyager.
Similarly, Voyager PAD is highly significant for revascularized symptomatic PID patients, demonstrating benefits for dual pathway inhibition. But again, it's not for asymptomatic PID. Making these distinctions crystal clear will demonstrate a high level of critical thinking and a consultant-level grasp of the evidence.
Excellent. Precision on trial applicability is key.
Mastering these points will allow you to confidently and articulately navigate an FRCS VIVA scenario on asymptomatic PA, demonstrating not just rote recall, but true, practical consultant-level application of the latest evidence. 8.8. Key take-home recommendations. Consultant level. A concise summary.
That was an incredibly comprehensive and sharp deep dive, full of essential insights. To bring it all together for our listeners, especially those gearing up for their exams, what are the absolute non-negotiable consultant-level principles you want them to internalize from this exploration of the ESVS 2024 guidelines on asymptomatic PAD? Let's pull the essentials.
Okay, here are the essential consultant-level principles that should guide every aspect of your practice and, crucially, underpin every answer you give in a VIVA scenario. First, remember targeted screening. We do not advocate for general population screening for asymptomatic PAD. Your effort should be precisely focused on screening high-risk individuals.
No other criteria.
You must know these specific criteria thoroughly. Patients age 65 plus, those 50-64 with risk factors, diabetes, smoking, dyslipidemia, hypertension, CKD, family history, under 50s with diabetes plus another risk factor, or patients with known atherosclerosis elsewhere. This targeted approach is a Class I IB Level B recommendation for focused screening.
Okay, number 1, targeted screening. Number 2.
Second, the ABI is key but contextual. The ankle brachial index remains the diagnostic cornerstone, a solid Class I Level B recommendation. However, always interpret ABI values, especially those 0.1.4, with extreme caution.
The incompressible arteries issue.
Exactly. This suggests incompressible arteries, common in diabetes or CKD, potentially masking disease. In such cases, be prepared to use the toe brachial index, TBI, or absolute toe pressures as essential additional diagnostic tools. These are Class IA Level B recommendations for inconclusive ABI readings.
Right. ABI is key, but watch out for high values and use TBI if needed. Third point.
Third, statins and aggressive risk factor control are for all L. This is the absolute core of your secondary prevention model. All asymptomatic PAD patients require high-intensity statin therapy. class 1, level C.
Statins for everyone.
Equally vital is aggressive blood pressure control, targeting A120 12 980 mmHg under 70, 130 300 980 mmHg over 70, class I, level A. For patients with type 2 diabetes, robust management is paramount, with SGLT2 inhibitors and GLP-1 agonists recommended first line, class I, level B, for their CV renal benefits. And permeating all of this, paramount lifestyle modification, especially smoking cessation, remains a class I, level A recommendation. This is your comprehensive systemic prevention strategy.
Okay, aggressive medical and lifestyle management for all. Number 4.
Fourth, regarding antiplatelets, only if another CV indication. This is arguably the most significant change. Do not routinely prescribe aspirin for asymptomatic PA patients for primary prevention.
The class 3, level A recommendation.
Exactly. The bleeding risk unequivocally outweighs any potential benefit. Only initiate antiplatelet therapy if there is an independent, compelling cardiovascular indication that requires it, like CAD or prior stroke.
No routine aspirin. Point 5.
Fifth, never revascularize asymptomatic PAD. This is unequivocal and non-negotiable. There is absolutely no role for revascularization, endovascular, or open surgery in asymptomatic PAD. The goal is managing systemic risk, not lymph flow without symptoms.
No revascing. Number 6.
Sixth, always remember the cost-effectiveness in patient counseling. Aggressive medical therapy aimed at systemic risk reduction is proven to be highly cost-effective. Patient counseling on crucial lifestyle changes, particularly smoking cessation, is not merely an adjunct but a foundational, first-line, crucial component for adherence and long-term outcomes. Your role in empowering patients here is immense.
Okay, medical therapy is good value, and counseling is key. And the final overarching principle.
And finally, always adopt a systemic perspective. Consistently frame PAD as a manifestation of systemic atherosclerosis. This dictates a holistic, preventative approach that addresses the patient's entire cardiovascular health, not just the lower limbs. This mindset is what elevates your practice to a consultant level.
Thank you so much for such an incredibly detailed and truly insightful deep dive into these vital new guidelines. It's clear that understanding these nuances and the why behind them really empowers our listeners to not just manage a condition, but to truly transform patient outcomes by preventing major cardiovascular events and, as you said, ultimately saving lives.
My pleasure. And while these guidelines provide excellent clarity and a robust evidence base for current practice, it's important to remember that the landscape of PAD research is always evolving.
Always more to learn.
Exactly. Consider the ongoing unresolved issues that still challenge us. The need for better anatomical classification systems covering all PAD stages, maybe the nuanced long-term risks and benefits of e-cigarettes when used as smoking cessation aids, or the true optimal thresholds for LDL-C in specific high-risk PAD subgroups.
Interesting points.
So the provocative thought for you, our listener, is this. How might you, in your practice or your future research, contribute to shaping the next generation of evidence-based care for these patients, pushing the boundaries even further?
A truly thought-provoking challenge to leave us with. Thank you for joining us on this deep dive, and we encourage all of you to continue learning, asking critical questions, applying these insights to make a tangible difference in your practice. We'll be back next time with another deep dive into the world of knowledge.